Most people assume that high blood pressure comes with warning signs, headaches, dizziness, a general sense that something is off. So if you feel completely normal, everything must be fine, right? That assumption is dangerously wrong. I have operated on patients who were living their lives normally just 1 week before suffering a stroke. This happens far more frequently than most people realize. Men and women who were walking their pets, preparing meals, sharing laughter with their grandchildren just days earlier. No red flags, no symptoms, nothing to hint at what was about to happen. Blood pressure does not give you a heads up before it causes serious damage, particularly not during the night, and particularly not after the age of 60. That is precisely what we are going to explore today. Here is the fundamental problem with how blood pressure is typically measured. Your physician checks it once during an office visit for roughly 30 seconds. 30 seconds out of the 86,400 seconds that make up your entire day. That brief snapshot is the foundation on which your entire treatment plan is built. And for most of those seconds, you are asleep. And that is exactly where things become very significant. Under normal circumstances, your blood pressure does something quite remarkable while you sleep. It decreases by approximately 10 to 20%. Every single night. This is what we refer to as the dipping pattern. It is not optional. It is your cardiovascular system performing critical overnight maintenance and restoration. Your heart undergoes repair. Your blood vessels recover. Your kidneys process waste. Every one of these biological processes depends on that nighttime pressure reduction. But here is what changes after the age of 60. Your arteries progressively stiffen. Your blood vessels lose their flexibility. The entire system begins functioning differently. And your autonomic nervous system, the one responsible for regulating that nighttime pressure drop, starts losing its precision. The signals become weaker and increasingly unreliable. For millions of people over 65, that nighttime dip simply stops occurring. The pressure either stays elevated or climbs even higher while they sleep. You wake up exhausted. Your mind feels foggy. You tell yourself you simply did not sleep well. But the actual explanation is something quite different, and most physicians never measure it because they are only looking at that 30-second snapshot, not the complete 8-hour picture, not even close. Let me walk you through a real-world example. A patient comes in with a blood pressure reading of 120/78, completely normal, absolutely textbook. I send him home wearing a 24-hour monitor. He goes about his regular day and falls asleep around 11 that evening. By 2 hours in the morning, his pressure has reached 164/102 while he sleeps, completely unaware. That is not a mild elevation. That is a serious hypertensive episode unfolding while he rests peacefully with absolutely no awareness that it is happening. How does this occur? There are 3 primary reasons, and each one becomes significantly more common after 60 than most people appreciate. First, his medication was taken in the morning. By midnight, its protective effect has nearly completely faded. The coverage gap is real and significant. Second, his stress hormones, cortisol and adrenaline, are not following their normal overnight rhythm. Rather than declining, they surge while he sleeps. Third, his sleep is fragmented. Every brief awakening, even ones he has no memory of, triggers a stress response and a corresponding pressure surge. And this happens night after night, not occasionally, every single night. The same surge, the same silent and accumulating damage, year after year. The damage builds invisibly within the walls of his arteries, within the tiny vessels of his kidneys, within the tissue at the back of his eyes. Month after month without a single symptom prompting him to seek evaluation. The body compensates quietly until one day it no longer can. We have a clinical term for individuals whose nighttime pressure does not drop. We call them non-dippers. And the statistics are quite striking. More than 50% of adults over the age of 65 are non-dippers, more than half. This is not a rare edge case. It represents the majority. Half the people in that age group are carrying a hidden cardiovascular risk that their morning blood pressure readings will never capture. What does this mean for health outcomes? Non-dippers carry a cardiovascular mortality risk 3 times greater than dippers who have identical daytime numbers. 3 times the risk. with the same daytime reading, the same medication, the same diet, simply based on what happens during those 8 hours of sleep. And then there is an even more concerning pattern: reverse dippers. These are individuals whose pressure actually increases during sleep, climbing higher at night than it is during the day. For reverse dippers, the likelihood of stroke increases by a factor of 4 to 5, and they feel entirely normal during a routine office visit. I want you to sit with that for a moment. Standard office visits detect none of this. None. Zero. That is the diagnostic gap we urgently need to close. Now let us discuss the items already present in your home that may be silently worsening your nighttime pressure. Some of these will genuinely surprise you. The first is licorice root. I understand that may sound completely harmless. It is an herbal tea, natural, soothing before bed, something many people enjoy. But licorice root contains a compound that inhibits a specific enzyme within your kidneys. Without that enzyme functioning properly, cortisol accumulates in your bloodstream. Elevated cortisol at night causes your pressure to surge. You do not feel it occurring. You simply wake up fatigued with no clear explanation. Check the labels on your evening teas tonight. Licorice root may appear as sweet root, glycyrrhiza, or buried within terms like natural flavoring in herbal blends. The second hidden factor is alcohol, specifically alcohol consumed in the evening. And what I am about to explain genuinely surprises most moderate drinkers. The initial sedating effect of alcohol does temporarily reduce blood pressure. That part is accurate. But 3 to 4 hours later, something else begins. Right during the deepest stage of sleep, a rebound spike occurs. Your sympathetic nervous system overcorrects. Pressure climbs sharply upward. Cortisol surges. Your blood pressure may reach its highest point of the entire 24-hour cycle at 3 nil in the morning. The third hidden factor is grapefruit juice, specifically when consumed alongside amlodipine or other calcium channel blockers that may be part of your prescription regimen. Grapefruit inhibits the liver enzyme responsible for breaking down these medications. The drug accumulates in your system. What was intended to be a gradual and controlled effect becomes dangerously prolonged. That unpredictability is especially concerning at night when there is no monitoring, no one nearby to observe symptoms, and no simple way to respond. So how do you actually determine what your nighttime pressure is doing? There is a test specifically designed to answer precisely that question. It is called ABPM, Ambulatory Blood Pressure Monitoring. You wear a small cuff for 24 hours while going about your life completely normally. It records readings automatically every 30 minutes, both during the day and through the night. This is the gold standard for identifying non-dipping patterns. It is the only reliable method for seeing your true overnight blood pressure profile, and yet most people over 65 have never worn one. Ask for it by name at your next appointment. If you do not specifically request it, it will almost certainly never be ordered. The second test is urine microalbumin. This measures tiny quantities of a protein called albumin that leaks into your urine when your kidneys are under sustained stress. Microalbumin is one of the earliest detectable indicators of organ stress from prolonged elevated pressure, appearing years before kidney function visibly deteriorates. It is a warning signal while there is still meaningful opportunity to change the trajectory, before damage becomes permanent, and before it shows up on any other type of test. The third test, and this one genuinely catches people off guard, is oxidized LDL. You are likely familiar with LDL as the so-called bad cholesterol. Oxidized LDL is what results when that cholesterol becomes damaged by free radicals, essentially deteriorated cholesterol that is far more destructive to arterial walls. Standard cholesterol panels do not measure it, but it serves as a direct marker of arterial wall stress, exactly what sustained nighttime hypertension accelerates. These three tests together, ABPM, urine microalbumin, and oxidized LDL, provide a clinical picture that no routine checkup ever delivers. They are affordable, widely accessible, and almost never requested unless you ask for them specifically by name at your next appointment. Write them down right now. ABPM, microalbumin, oxidized LDL. That is your complete agenda for the next time you visit your physician. Now let us talk about solutions. beginning with the most commonly overlooked one: the timing of when you take your existing blood pressure medications. Most antihypertensives are taken in the morning. That is the established convention. That is the ingrained habit. But is it actually the most effective approach for protecting you overnight? The protective effect of most blood pressure medications peaks within a few hours of being taken, then gradually and steadily diminishes throughout the day. If you take your medication at 7 cars in the morning, by midnight, its protective window has substantially narrowed, right at the time when you need it most. There was a landmark study that addressed this directly, the Hygia Trial. 20,000 patients, 6 years of follow-up, one of the largest studies of its kind ever conducted. Researchers compared patients who took their medications in the morning against those who took the identical medications at bedtime. Everything else remained equal. The findings were remarkable. The bedtime group demonstrated nearly 50% lower rates of heart attack, stroke, and cardiovascular death. Nearly 50% reduction from simply adjusting when the medication was taken. Same medications, same doses, different timing, dramatically different outcomes. Not changing prescriptions, not increasing doses, not adding new drugs, just taking what they already had at a different time of day. I must be completely clear. Do not adjust your medication schedule on your own. Speak with your physician first. This step requires a direct and specific conversation. Some medications genuinely should not be taken at bedtime, diuretics especially. Your doctor needs to review your individual situation before any change is made, but that conversation is absolutely worth initiating. One question at your next appointment could reshape your entire treatment approach. It takes 30 seconds to ask. Let me tell you about something with genuine clinical support sitting quietly on the shelves of most health food stores: hibiscus tea. Specifically, the dried flowers of Hibiscus subderiffa. And before you dismiss this, allow me to share what the clinical trials actually found. Hibiscus contains compounds called anthocyanins, the same molecules responsible for the rich, deep color in blueberries, pomegranates, and red cabbage. Anthocyanins are potent antioxidants. They neutralize free radicals, the molecules that damage arterial walls and directly contribute to oxidized LDL. But hibiscus does something additional. It inhibits ACE, the angiotensin-converting enzyme, the same enzyme that a major class of blood pressure medications targets. That is not a coincidence. That is a pharmacological mechanism found in a plant, studied in trials, and replicated across multiple independent research groups. Multiple clinical trials have demonstrated consistent blood pressure reductions in patients with mild to moderate hypertension who consumed hibiscus tea daily. We are talking about reductions of 8 to 14 millimeters of mercury in systolic pressure among patients not currently on medications. That is clinically meaningful. Now, preparation matters considerably. Weak hibiscus tea has minimal therapeutic value. Most people are preparing it far too diluted to experience any noticeable benefit. Use 10 grams of dried hibiscus flowers, not tea bags, not blended products, actual dried flowers. Water temperature at 90 degrees Celsius. That detail is important. Steep for 10 to 15 minutes, not 5, not 7, 10 to 15. The steeping duration matters for the active compounds to fully release into the water. When properly prepared, the color should be deep burgundy, almost resembling dark red wine. If it appears pale pink, you need to steep it considerably longer. 3 cups per day is the dosage examined in the clinical literature, but the most important cup is the one consumed in the evening, 1 to 2 hours before sleep. That is the timing window where it has the most meaningful influence on what happens to your pressure overnight. One important note of caution: if you are already taking blood pressure medication, do not introduce hibiscus without informing your physician first. The combined effect can be additive. This is not meant to discourage you. It is simply a reminder that even natural compounds with real biological mechanisms interact with real prescription drugs. Have that conversation with your doctor. You have just absorbed a substantial amount of information. Let me bring all of it down to 3 specific actions you can take tonight. Just 3. First, go to your tea cabinet right now. Read every label carefully. Look for licorice root, which may also be listed as glycyrrhiza, sweet root, or natural flavoring. If you find licorice root in your evening tea, that tea moves to the morning shelf or out of the household entirely tonight. Second, be genuinely honest with yourself about your evening alcohol consumption. Not self-critical, just honest. Is it happening regularly? Is it close to bedtime? If so, understand that the rebound pressure spike is real. It is occurring at 3 naws in the morning, whether you feel it or not, every single time. You do not need to eliminate it entirely, but consider shifting it earlier, with dinner rather than in the hour immediately before sleep. Third, take out a piece of paper and write down 3 things: ABPM, microalbumin, oxidized LDL. That is your list. That is all. Fold it. Place it next to your insurance card. That piece of paper is your complete agenda for your next physician appointment. 3 items: affordable, accessible, and capable of giving you the clearest possible picture of what your cardiovascular system is doing while you sleep. These are not optional additions. These are the tests that reveal what your morning office visit was never designed to detect. Here is what I want you to understand at the most fundamental level, and why I devoted this entire discussion to a single focused topic. Your cardiovascular system never stops working. Right now, as you watch this, your heart is beating. Your vessels are under pressure. It never rests, not once. And after 60, the margin for sustained undetected damage is narrower than it was at 40 or 50. The body is extraordinary at compensating, at absorbing damage quietly, without complaint, without symptoms, until one day a threshold is crossed. And that threshold for many people is crossed at night, while they sleep, while they dream, without a single visible warning sign. I have been present at bedsides following strokes and major cardiac events. I have had those conversations with families, and I remember every one of them. In a significant number of those cases, especially involving patients over 60, the warning indicators were already present. In data that was never gathered, in nighttime readings that nobody ever took, in microalbumin levels slowly rising year after year, in arterial stiffness quietly developing in the background. In many of those situations, the outcome could have been different, with one additional test, with one well-informed question at one appointment. Preventable in many cases, yes, not all. Medicine is humbling, but far more preventable than most people believe when they have access to the right information, when they ask the right questions, when they pursue the right tests, when they have one meaningful and informed conversation with their physician at the right moment. You have every right to that information, every right to ask about nighttime pressure, about ABPM, about medication timing, about these tests. You are not being difficult. You are not being unreasonable. You are being a responsible and engaged participant in your own healthcare. That distinction matters enormously. And that level of engagement, based on decades of observing patients navigate this system, genuinely saves lives. Not as a slogan, but as a clinical reality. Patients who ask questions, who bring prepared lists to appointments, who follow up consistently, they receive better care. The evidence on this is clear and consistent. You have something today that most people do not have when they walk into their physician's office: specific, targeted, actionable information. Let me bring everything together. I want you to leave this discussion with complete clarity, not just information, but a defined plan. Your daytime blood pressure reading is a starting point, not the full picture. Nighttime pressure matters just as much and often more. More than half of adults over 65 are non-dippers, carrying 3 times the cardiovascular risk of individuals with identical daytime readings. 3 times, with the same office reading, the same medications, the same dietary habits, simply from what unfolds during those 8 hours of sleep. Almost never identified through routine visits. A hidden risk that most people carry without ever knowing it exists. There are items in your home making this worse: licorice root in your evening tea, alcohol consumed in the evening, and grapefruit juice taken alongside certain medications. 3 tests reveal the complete picture: ABPM, urine microalbumin, and oxidized LDL. available, affordable, and rarely ordered without a direct and specific request. Bedtime medication timing, supported by 20,000 patients in the Hygia Trial, can reduce cardiovascular risk by nearly half for the right patients. And hibiscus tea, 10 grams, steeped to a deep burgundy, consumed 1 hour before bed, carries genuine clinical evidence as a supportive daily measure. 3 steps. 1. Check your tea cabinet tonight. 2. Write down ABPM, microalbumin, oxidized LDL. 3. Ask your doctor about evening medication timing. Has your physician ever discussed nighttime blood pressure with you? Have you ever worn a 24-hour monitoring device? Share your experience in the comments below. I read all of them, and your perspective genuinely helps others in this community know what questions to bring to their next appointment. If this video provided you with something valuable, please consider sharing it with someone over 60 whom you care about, a parent, a spouse, a close friend. This is precisely the kind of information that gets lost between appointments and referrals. Your share could be the connection someone else genuinely needs. Subscribe if you want to continue exploring cardiovascular health after 60. There is considerably more important ground to cover, and we are just beginning. One final point, and I want to be entirely direct about this. Everything shared today is intended for educational purposes. It reflects current research and my personal clinical background in cardiac surgery, but it is general information, not individualized medical advice. Your circumstances are unique. Your medications are specific to your history. Your biology is individual to you. Please speak with your own physician before making any changes, before adjusting your medication schedule, before beginning any supplement, before making significant dietary modifications. Your doctor needs to be part of that conversation. That conversation is not a formality. It is the entire point. Better information leads to better conversations, which lead to better outcomes. That is the sequence that matters. Take care of your heart. It has been working for you every single hour of every single night without interruption, without rest, without complaint, for every decade of your life, every year, every night, silently and faithfully performing its role without ever asking for anything in return. The least we can do is pay attention, ask the right questions, pursue the right tests, and have the right conversations with the right people. You now know exactly what those questions are, which tests to request, and which conversations to initiate. That knowledge carries real, measurable value. Walk in prepared. That is the entire message. Walk in with your list. Walk in knowing what to ask for. That changes everything. I will see you in the next video. Until then, take exceptional care of yourself and of the people you love. And if you have questions or would like to share your own experience, the comments section is open. Subscribe to this channel for more content.